Hello students, I think recently we had a discussion on examination of thyroid, clinical discussion in the malignant thyroid, that is thyroid malignancy. So we had a lengthy 1.5 hour discussion. Before going through this lecture, please go through this that live session which is there in our YouTube, so that we'll have the how exactly examine a patient with the thyroid swelling in special reference to thyroid malignancy. So once you go through that, if you go through this lecture about thyroid malignancies, which I am going to discuss basic understanding about thyroid malignancy, then you will understand this subject, have a better idea. So I'm going to discuss about thyroid malignancy. So remember, thyroid malignancy is one of the malignancy which is easily accessible, often curable in a better rate percentage than other malignancies, may be associated with the many syndromes, often familial and so on. So it is not uncommon, and it is more common in females. So all these points you have to remember when you discuss about the thyroid malignancies. So older classification is different, where Dunhill classification is preferably used. But currently, it has changed in 2022 is WHO classification. This is the one classification which is currently used, started in 2022. Older classification, I think, also you have to remember, which I have put in the later slide, because it is practiced for a long time, that is the Dunhill classification. Definitely it will be asked in the exam. But this is the current classification, remember. Follicular cell derived neoplasm in that benign tumors, low risk neoplasms like non-invasive follicular thyroid neoplasm with the papillary, like it's a short form of non-invasive NIFTN, like that it is often called, and thyroid neoplasm, the uncertain malignant potential, highly, all these things are the classification under that actually. Malignant neoplasms, follicular thyroid carcinoma, invasive encapsulated variant of papillary carcinoma. Papillary, this is the commonest, of course. Papillary carcinoma is the commonest thyroid malignancy. Remember, it's MCQ question, usually around 60 to 70% common. Next is follicular carcinoma of thyroid and others, of course. Oncocytic carcinoma of thyroid, follicular derived carcinoma, high grade, differentiated high grade thyroid carcinoma, poorly differentiated thyroid carcinoma. So the newer entities which we come across in this classification, which we earlier were not usually practicing this newer classification actually. So all this different newer entity has come into the picture, which we have to remember, because it has got its own specific importance, because it's aggressive. Treatment requires rather aggressive treatment, and behavior also aggressive, and maybe mortality also a little higher compared to basic papillary carcinoma of thyroid and follicular carcinoma of the throat, otherwise PCT or FCT. Anaplastic carcinoma, follicular cell derived thyroid neoplasm, anaplastic, all of you know that is a very aggressive malignancy which lasts for few weeks, aggressive, gets fixed to the anteriorly to the skin and soft tissues, often posterior to the carotid, prevertebral fascia, becomes fixed, causes stridor at rest, and locally spread very fast, and often life-threatening. Very aggressive malignancy of thyroid carcinoma. Luckily, it is less common compared to papillary carcinoma thyroid and follicular carcinoma thyroid. But remember, long-standing papillary carcinoma thyroid for many years. Papillary carcinoma thyroid is the one malignancy which can last for many years, remember. So size is not a criteria, consistency is not a criteria, and texture is not a criteria. And the long-standing papillary carcinoma thyroid can suddenly become aggressive by turning into what is called as anaplastic carcinoma thyroid, which is more or less life-threatening. So C-cell derived carcinoma, that the medullary carcinoma thyroid, because basically it is not from the thyroid, you know that parafollicular C cells are there. Thyroid, parafollicular C cells are within the thyroid gland, even though functionally and topographically, embryologically they are different. Parathyroid is very close to the thyroid gland, so that's why it's important when you do thyroid surgery, because when doing dissection, you may remove thyroid, may cause hypocalcemia. Of course, other thing is the recurrent plunging node. So the surgical anatomy is the most important, a very compact structure where this thyroid is deep to the pretracheal fascia, deep to the investing layer of the fascia, and both lobe, it's a butterfly shaped, and it moves upward with the deglutition do Berry's ligament, which is the condensed pretracheal fascia posteriorly, superiorly, which connects the cricoid cartilage to the thyroid. So that's why it moves upward with the deglutition. That's a clinical important finding. Why this is thyroid? Because thyroid moves upward during deglutition because of the attachment of the Berry's ligament. Berry's ligament is nothing other than the condensed deep fascia posterior-superiorly. This is a point which you have to remember. Of course, this is totally different, but features are same as, clinically it is same as thyroid swelling as such. And of course, it has got a high calcitonin level. It runs in the family. Amyloid deposition within the malignant cells is dispersed within the tissue, malignant tissue, adjacent to the malignant cells, is one of the known specific histological feature to diagnose medullary carcinoma thyroid, other than the tumor marker, is high calcitonin level, often familial, runs in the family members, wherein family members ideally should undergo prophylactic thyroidectomy, even though they had to get a disease. So that is the point which you have to remember. Medullary thyroid carcinoma comes under thyroid, discussed under thyroid, even though basically not related to the thyroid as such. So thyroid malignancies, I am just discussing Dunhill classification. This is the, I have discussed earlier classification. Now this comes, this is the older classification which is still practiced. Differentiated thyroid cancer, in that papillary carcinoma thyroid, follicular carcinoma thyroid. Undifferentiated is anaplastic carcinoma thyroid. Medullary carcinoma thyroid, already told C cell of the pancreas, C cell of the thyroid. Lymphoma can occur, secondaries in the thyroid. All these things are rare, but two can occur. Remember, male is the high risk factor. It's commonly in the females. Remember, all thyroid diseases, hypothyroidism, toxic thyroid, benign thyroid swellings, maybe multinodular goiter, colloid cyst, colloid goiters, or solitary thyroid, nodule thyroid, adenomas, carcinoma thyroid. All these things are common in females, but it too can occur in the males. And when it occurs in the male, they are high risk. Thyroid swelling in the male is high risk because they have got high malignant potential. So thyroid swelling is not very common compared to the females in males, but when it occurs in the male, suspect carcinoma in males. This comes as a high risk group as usually. This is again carcinoma here in a female patient, and papillary carcinoma spreads through lymphatics. Papillary, follicular, medullary, anaplastic. These are the four common things you have to remember, of course. Classification I have told, poorly defined thyroid carcinoma and so on. Papillary carcinoma spread through lymphatics. Follicular carcinoma thyroid spreads through blood. Anaplastic by both MCT, both blood and lymphatics. It's important. Papillary carcinoma thyroid is often curable. It is usually spread to lymphatics, uncommon spread to the blood. Of course, size criteria is there. Intrathyroid spread is common. From the one site focus, it can go to the within thyroid other site also through intrathyroid lymphatics, or it may be multicentric also. Many places malignant cells can, so either it can be multicentric from one place to other site can spread also. This is locally, basically, loco-regionally malignant. You know that malignancy can be locally malignant, loco-regionally malignant, or distant spread. Locally malignant means it only within the tissue, like basal cell carcinoma, marginal ulcer, varicose carcinoma, and so on. Local, it does not spread to lymphatics nor through the blood also. Of course, once it becomes aggressive again, that's a different story. Otherwise, I'm telling differentiated type. Whereas loco-regionally is like papillary carcinoma thyroid plus regional lymph node. Squamous cell carcinoma in the skin plus regional lymph node. Oral carcinoma, carcinoma with neck lymph node. Usually they are loco-regional diseases. Exceptions are there, I'm not going to discuss. And other is systemic disease, like malignant melanoma, systemic disease, adenocarcinoma, systemic disease, carcinoma breast is systemic disease, like their differentiation. So these are the three categories based on their biological behavior in relation to the spread potential. That is any malignancy you can think of. So local is better, local regional is little aggressive, whereas a little more aggressive, whereas systemic is very aggressive. That is how we have a concept about the malignancy which also holds good here. Papillary carcinoma thyroid is local regional, follicular carcinoma thyroid is have got systemic spread potentiality, anaplastic is very aggressive, medullary carcinoma is again both lymphatic and blood spread as such. So etiology, I am not going to detail any of these etiologies. My current edition, SRB's Manual of Surgery, detailed etiology is, upgraded etiology is there, radiation, syndromes, family nature, then previous multinodular goiter, so many etiologies are there, Hashimoto thyroiditis, genetic syndromes, all those things are the different etiologies are there. You can detail, go through this etiology in my book, because often asked as a short note, MCQ, they can ask. Short note again, just classification, just remember radiation, familial, multinodular goiter. This is mainly follicular carcinoma thyroid. This is mainly papillary carcinoma thyroid. This can be MCT or papillary carcinoma thyroid, both. You got special chromosomes are there. Hashimoto thyroid is mainly papillary carcinoma thyroid plus lymphoma, it can come into. Mainly papillary carcinoma thyroid, remember, not lymphoma, but lymphoma also can occur in a Hashimoto thyroid. Many times people have confusion that Hashimoto thyroid, because of it has got lymphocytic infiltration, it has got high potential to turn lymphoma. That is true. But common malignancy which occurs in a backup of Hashimoto thyroiditis is papillary carcinoma thyroid, but it can potentiate lymphoma also. So remember, again, important point I want to express here is Hashimoto thyroid is not uncommon, remember, it is quite common. Many females at the age of 40, we see painful, tender thyroid swelling, eventually become painless. Initially, there will be hyperthyroid, then becomes euthyroid, then becomes hypothyroid, because initial inflammation causes more inflammation, causes the secretion of thyroid, thyroxine, so toxic thyroid. Eventually, inflammation subsides, becomes euthyroid. Then slowly fibrosis occurs, function reduces, becomes hypothyroid. And over the pretty long time, it may turn into papillary carcinoma thyroid commonly, and often may turn into lymphoma. This is a point which you have to remember, because genetic syndrome, Cowden syndrome, carcinoma, thyroid, breast, colon, or so many things are there. You can always read in my book, Cowden syndrome. There are so many other syndromes also it may be. So these are the points which you remember in the exam, so that you can expand it and write. MNG, remember, multinodular goiter, mainly follicular carcinoma thyroid. So this is the precursor disease actually for follicular carcinoma thyroid. Remember, all this I've already told. BRF mutation, NTR fusion, that's chromosomal level. RAC mutation, PPR mutation. I'm not discussing, maybe useful for your MCQs. All these poorly thyroid cancer, unprotected thyroid cancer, all these things are the MCQ related points which you may have to remember when you go for entrance exam or NEET exam eventually, or any entrance exams. If you take, these things are quite important. And most common thing is papillary carcinoma thyroid, 60 to 70%, I already told. Radiation, genetic, Hashimoto thyroid, familial, all those things. The details you can always go through my manual. Variants are important, which remember, there are currently newer variants are there. Micropapillary, that is a good, less aggressive, small one. So they're curable, remember. Papillofollicular, papillary and follicular, they behave like a papillary. Linde disease, encapsulated variant. Otherwise, currently it is called as non-invasive follicular thyroid neoplasm with papillary-like nuclear features, NIFTP, already told in 2022 WHO classification. It has given very much importance because it is said to be becoming more and more common, and diffuse sclerosing type. And it is important because its behavior is little different from the usual papillary carcinoma thyroid. Aggression also different, spread also little different. So treatment strategy also may vary. Prognosis, further evaluation, follow-up also, you have to chart out differently in these patients. That's why it is important. What is important, you have to remember, is black and brown colored fluid in all these things. If you this is the thyroid, this is the thyroid, this is the isthmus, this is the swelling here. If you look at the nodule, malignant nodule, if you look at the nodule gross wise pathologically, it is dark black or dark brown color. And if you aspirate on or open after surgery, if you cut open and see, it will blackish or brownish color. So very typical, because dark, mainly colloid it contains, so that's why it is blackish or brownish color. So color of this malignancy tissue is in papillary carcinoma, black and brown colored. This is the point which you have to remember. And neck lymph nodes are commonly lymph node. These are the main lymph node 2B, 3, 4E, 4, 4, 4. These are the main lymph nodes actually here. If this is there, this is the 1A, 1B, 2B, and 3, 4. These are the lymph nodes are which commonly node. If this is the thyroid, these are the lymph nodes which commonly node 2B, 3, 4. You know the level 2B, 3, 4. So this is the point where because these lymph nodes are involved, because they are not primary thyroid lymph nodes. You know, the primary thyroid lymph nodes are pre-thyroid, pre-laryngeal node that is called Delphian node, single node between the two cricothyroid, and pretracheal nodes, paratracheal nodes. Delphian node, single node. The subdelphian nodes, paratracheal nodes. They are primary nodes. They are very commonly involved by the thyroid malignancy, but clinically not palpable. Often difficult to assess radiologically also. Means sonologically also, because sonology is the main investigation for thyroid swelling, and in specific for thyroid malignancy because features will be different, and also vascularity will be different. There is some vascularity index also for these things, and also lymph nodes if involved, its features are different in malignancy compared to the benign lymph nodes. Where difficult to pick up these lymph nodes in the primary, whereas secondary lymph nodes are 2B, 3, 4. They are common. They are once involved. Of most of the time, primary lymph nodes are getting involved. That is the concept. So if it is so, these lymph nodes are involved. You have to do FNH of these lymph nodes, and you have to confirm and do a neck dissection. Maybe modified neck dissection. That's a different thing. But you need to do that, especially concentrating in lateral area. There is lateral neck dissection, selective, 2B, 2, 3, 4 like that. So microscopy. This is again important. Some of our bodies. Remember. Some of our bodies are calcification because of the calcification, the fine calcification in the papillary carcinoma thyroid, whereas a coarse classification in a long-standing multinode goiter. If we take an X-ray, sonologically also we will be able to make out this. The very important calcification is one of the important features in the thyroid imaging. And the some of our bodies are also seen in meningioma, also seen in the serous adenocarcinoma of the ovary. 3 conditions. But in thyroid, papillary carcinoma thyroid. Papillary carcinoma thyroid, serous adenoma of the ovary, and meningioma. And here very specific orphan unniae nuclei is again very important. Tall type is again this when these cells are tall type, columnar type, different types are there. Where which is aggressive histologically is a cell tall type is very most aggressive. So it's important because there is more tall type percentage wise. Then that person disease is aggressive, spread is common. Recurrence is common, and more radiotherapy, radioactive iodine therapy dose as such. So all these things are important to eventually plan the thing. Spread may be multicentric, I already told. Maybe intrathecal lymphocyte spread or later extrathyroidal. If this is the thyroid, if this is the primary tumor, it may spread to the other area also, to the intrathyroid lymphatics, or often if there are multiple tumors, multicentric, all are primary big started de novo, but in different places. So one area spreading to other to intrathecal lymphatics, or multiple places it starts. So finally, at the end of the day, it doesn't make any difference because behavior is same in these patients. But pathological is important because one focus, multiple focus. That's a different thing. That's a point you have to remember always. And later it spreads, comes out of the thyroid tissue. That is called extrathyroidal. Initially it is intrathyroidal, later it becomes extrathyroidal. Eventually it may become aggressive of a long time, maybe often many years. Then it may get adherent to the fascia, carotid sheath, skin, soft tissue, strap muscles, posteriorly period of fascia. That point of time may turn into anaplastic carcinoma with respect to the primary lymph nodes and secondary lymph node later period. Primary lymph nodes I already told in the midline, level 6, where secondary lymph node 2, B, 3, 4. That point you have to remember because MCQ they will ask. So features are maybe firm, hard, cystic, solitary, multiple. Size is not a criteria. Small size also may be malignant. Very large multiple size also may be malignant. Size is not a criteria. Texture is not a criteria. Consistency is not a criteria. And duration is not a criteria. That is why we were taught in olden days by our professors, teachers. Any thyroid can be malignant unless proved otherwise. But commonly thyroid swellings are benign. But malignancy, your job is to pick up the malignancy, and pick up the malignancy because the swelling, which can turn into malignancy, which will turn or not. If it is not turning, being very benign, you can always wait and watch. There are criteria, they're different. I'm not going to discuss that. You can always read in my book, SR with Mangalore surgery, current edition, a specific 8th edition, it is there. So you can read, and I understand this thing, all new concept which is written there. So important thing is, any thyroid can be malignant unless proved otherwise. Our business as a clinician to rule out it is not malignant, confirm that it is not malignant, it is not potentially malignant also. Distant spread is rare, but part of DCC more than 3 centimeter, which you can have a secondary. That's important. One is immunosuppression, when the second is syndromes, third is more than 4 centimeter. Then can have a blood spread, which may behave. That's why differentiated thyroid cancer, one heading as they have put into that after Daniel classification. That is the DTC is papillary and follicular together, because biological behaviors are overlapping. So very olden days they said papillary thyroid, no radiotherapy, radioactive therapy. Now currently it is not so, because it comes under the umbrella of differentiated thyroid cancer, wherein specific criteria is high risk, multicentric, size more than 4 centimeter, lymph nodes are there. Such a patient, you need to give radioactive therapy after total thyroidectomy with or without lymph node dissection. So need to give. So all these criteria are they want to do. So behave like a follicular or behave like a DTC. Basically DTC. So where you need to give the radioactive therapy in this patient. Remember, chemotherapy is not going to help much for most of the thyroid malignancy, including specifically I'm telling that is papillary carcinoma of thyroid. So all these things you can always refer my book, thyroid chapter. So this is the classification for occult, small one, because less behavior, less aggression, only one focus, then you can do a hemithyroidectomy, otherwise a total thyroidectomy. General concept is currently total thyroid. You have to remember total thyroidectomy. Unless there is a specific points you have got to say that I will do hemithyroidectomy and observe the patient. Okay. Advantage is no thyroxine, no calcium, no hyperparathyroidism. So no supplements in those patients. Disadvantage is you cannot give radioactive iodine therapy. You have to do a follow-up in these patients, and they may get a disease on the other side, which we are not sure whether there's intrathyroid spread or a small focus, de novo, independent. So all these things are the possibilities which you have to think of in papillary carcinoma thyroid. So currently concept is total thyroidectomy. But only thing is, in specific situations, you can do hemithyroidectomy and observe the patient. So intrathyroidal, extrathyroidal already told. So size is important. This is the good old Ulnar classification, often asked as a MCQ question, which you have to remember. So investigations, already told behavior, less aggressive, maybe multicentric, maybe intrathyroidal spread, one lobe or other lobe, duration may be longer, lymph node spread, I said primary lymph node, delphian lymph node, pre-laryngeal, pretracheal or sublaryngeal, it is called paratracheal. Secondly, 2B, 3C, lateral neck lymph node. So aggressive tumor may spread into the, I said aggressive types may spread to the, so now size bigger than that. So, or with certain situations, it may become a metastatic disease where behave like a FCT or DTC with respect to the skull and so on. So other places. So ultrasound neck is a specific investigations. Proper ultrasound neck gives a clear idea about size, texture, vascularity, lymph node status, lymph node features of the malignancy. You can always go through my book. It is there. What are the lymph node features to say these are the malignancies? Ultrasound guided FNS is very relevant. It shows the phenomena bodies and the other phenomena bodies. It shows orphan onion nuclei. Almost near 99% sensitivity is there. Radiation scan which shows whole nodule. That's important. Iodine 131, diagnostic scan, not therapeutic, remember. Iodine 131. But technetium M99 can use for diagnostic purpose, not therapeutic purpose. So this is given, technetium is given IV. This is given always oral. Okay, its half-life is around 8 days, whereas this is not so. This is IV, short duration, short this one. It's IV for diagnosis, only for diagnosis, not therapy, technetium. IV it is given. Iodine 131 is the usual thing for diagnosis, small dose, 5 microcurie. Therapy for 5 millicurie, higher dose. So plain X-ray neck may show calcification, fine calcification. One undergot shows coarse calcification. Already told fine calcification specific of the in plain X-ray papillary carcinoma of thyroid. Thyroids, this is important. Thyroid imaging and recording, and this is American College of Radiology, thyroid imaging reporting and data system. Thyroid imaging reporting and data system. Like same BIRADS, breast imaging reporting and data system. Like BIRADS. In BIRADS, it is 6 are there. Here it is 5 only, 1 to 5. You can always read in my book, it is there 1 to 5. What are the features? There are different features to say 1, 2, 3, 4, 5. So it becomes, if it is 4, 5, the high chances of becoming malignancy. Thyroid imaging, reporting and data system. That is often asked as MCQ question. Short note may be asked, you have to know. You can always read my manual of surgery. It is given in detail about that. Similarly, BIRADS for the breast, 6 are there. Again, read my book, breast chapter. You can always understand what exactly it is. It's also a main short note as such. So treatment for PCT, total thyroidectomy, remember. Olden days we used to do near total thyroidectomy, although no, currently no partial thyroidectomy, no subtotal thyroidectomy. Near total is still some places it is accepted. Small tissue we train very close to the recurrent laminal and parathyroid, that's still accepted. But ideally, the total thyroidectomy, so that you remove entire gland. So make the radioactive iodine therapy have a more efficacy. If you retain the thyroid gland, radioactive iodine therapy concentrate on the thyroid, so it won't be useful to kill the proposed spread through the lymph nodes and other areas. So that is the idea. So ideally you should do total thyroidectomy, but near total thyroidectomy, wherein you small tissue close to the parathyroid and recurrent you can retain, that is also still accepted in some books, definitely accepted, but total is ideal. And lateral neck dissection when it is positive. Suppressive dose of L-thyroxine later is important. When you remove a thyroid disease for benign disease, multinodular totally, or for medullary carcinoma of thyroid, whereas that is not the thyroxine dependent, and you don't require to give suppression, you don't require to TSH dependent, you don't require to suppress the TSH level in medullary carcinoma of thyroid, whereas in papillary carcinoma of thyroid and part of the follicular carcinoma of thyroid, you have to suppress the TSH, where you need to give high dose thyroxine, 0.3 milligram or 300 microgram empty stomach before food, where they will have a features of mild toxicity, cardiac irregularity, osteoporosis. Which are the complications of thyroxine: osteoporosis, cardiac irregularity. These are the main complications of the thyroxine, osteoporosis, cardiac irregularity. So you have to monitor these patients, but you have to, once you develop that means suppressors, TSH level should be very low. Otherwise, malignant cells, whatever retained cells may proliferate. That is a concept, it's an idea. That is called suppressive dose of therapy. Whereas in any disease where other than these papillary carcinoma, follicular carcinoma, thyroid, when you operate, you don't require there is no need to suppress the TSH at all. So you have to give a maintained dose of L-thyroxine, that is 100 microgram. So maintained dose 100 microgram, 0.1 milligram once a day before food. Always we have to give before food for lifelong. Suppressed dose is 0.2 to 0.3 milligram, 200 to 300 microgram before food. Again for lifelong. Monitor the patient with the proper TSH level. That's important. TSH should be very low in papillary carcinoma of thyroid after surgery to prevent the recurrence. So if tumor less than 1 centimeter, solitary, low grade, remember, unicentric, then only you can do the hemithyroidectomy. So most often our patients will come beyond that. So unless likely to land with the hemithyroidectomy. There is a role, of course, role of central neck dissection. There is again controversy, but because it is very commonly involved, you have to remove the prelaryngeal, pretracheal, paratracheal lymph node, level 6 node up to the innominate vein. You have to remove all nodes. So clear, so that because it is said that very commonly these nodes are involved, even though clinically not detectable, sonological not detectable. That's the idea. So clear everything, give a proper radioactive iodine therapy, and do a proper follow-up, and such patients will have a complete cure, because one of the curable malignancies, remember, papillary carcinoma thyroid. But only thing is there high chance of hypoparathyroidism and also high chance of injuring the recurrent laminal nerve when you do this aggressive surgical dissection in a compact area like this. So role of central necklace is definitely acceptable, but not prophylactic. They said involved if you have to do it, may have to do a frozen section biopsy on table when you do surgery for malignancy, and if it is involved, do it definitely useful. But there are controversies. Many people do the central neck dissection as such because it is said that 80% of patients it is involved, not like lateral neck dissection, it is not late. They are secondary lymph nodes. Radioiodine therapy is a must once it is a large tumor, aggressive tumor, high-grade tumor, and multicentric tumor, extrathyroid tumor. Then you have to give a radioiodine therapy, iodine 131 therapy, usually given orally, liquid citrus. You have to order it, then you have to isolate the patient for a few days. You have to, their urine excrete has to be taken care of because to prevent the radiation as to others. They should avoid going to the children. They have a dry saliva, so they keep on eating chocolates and other things, so increase the salivation. So there's the different thing which I always say, you can read my book. What are the precautions you will take when you give radioiodine therapy? What is the dose? Everything is there in my book in malignant patient. But this is the important thing. It's often short note for you. The treatment of PCT is a short note also again. These are the different gradings they use, AMES, AGS, and I'm not going scoring system. I am not going to detail it, but definitely there are boxes about these scoring in my manual of surgery, current edition. You can read and recapitulate because often asked in the MCQ. Me ask in the Viva, yeah, because long case, thyroid is always a long case in the exam. So malignancy is going to discuss, especially papillary carcinothyroid, because it is a commonest malignancy. So somebody usually they will ask, what is the commonest malignancy? 60 to 70% it is the papillary carcinothyroid. So naturally, everything about papillary carcinothyroid will be discussed as a continuation. So treatment, iodine therapy, follow-up, scoring system, at least few scoring system, full form you should remember. So go through my manual of surgery. So it will give a real correct idea about papillary carcinothyroid and all these scoring system. It's a specimen, remember, of the total thyroidectomy of exactly it looks like. So follicular carcinothyroid is less common but more aggressive. De novo or in pre-existing multinodular goiter. Blood spread is common. It can spread lymphatics as a part of component of DTC, but mainly blood spread, less lymphatic spread. This is more dangerous, especially skull bone. Here, frontal bone, skull bone. Of course, the long bones can occur. And usually they are localized, soft, highly vascular because of the angiogenic factors and angiogenic growth factors. It is really vascular. Along with that, it causes the destruction of the outer table and inner table, and it secretes colloid. It's a functioning one because still differentiated, so it functions. It secretes colloid, so it contains colloid. So often pulsation becomes easily felt. Otherwise, all skull secondaries, the different causes, maybe sarcomas, maybe RCC, maybe occasionally carcinoma breast, and different conditions can cause bone secondary, specifically skull. They are hard, non-pulsatile, well localized, but can be warm because of the vascularity. But here, warm, vascular, well localized, soft, pulsatile because outer table and inner table destructed, and it contains colloid. All other secondaries from other malignancies, content is solid. Here, the content is liquid-like, not exactly soft. It is because of the colloid. Soft. That's why pulsation is felt because of the vascularity, as well as brain pulsation may be truncated because both outer table is inner table is destructed. So there's a point which you have to remember. It can infiltrate locally. It may cause stridor at rest, hoarseness of voice. It's important for all malignancy. Hoarseness of voice is a very typical feature. Not only malignancy, it says there is advanced malignancy, local infiltration, dyspnea, occasionally dysphagia, stridor at rest. Cocker's test is different, where it is stridor on compression, posteriorly, from the lateral to medially, inward. Inward, when you do a compression, they will get a stridor because the thyroid trachea is a C-shaped. Front it is a cartilage, posterior tracheal muscle, because tracheal rings are getting weakened, so it collapses, causes stridor. So that is a sign of compression, not a sign of infiltration. Remember, Cocker's test is a kind of compression, whereas a sign of infiltration is in malignancy, where stridor is they walk into the OP, in surgical OP or thyroid OP with the stridor. It's a sure sign of malignancy infiltrating the trachea. Compression is different, where you have to elicit the compression by Cocker's test. So Berry's sign, when necrosis is infiltrated, Berry's sign, Berry's ligament, berry picking is no more practiced in thyroid surgery. The 3 berries in the thyroid, berries, berry ligament, berry sign, absence of correct pulsation because of the thyroid malignancy infiltration, berries, that is berry sign. Berry ligament, already I have told. Berry's ligament, berry's sign, berry picking or cherry picking is not there now. FNAC is inconclusive in FCT, whereas papillary carcinoma FN is diagnostic here because 2 things are important here, capsular invasion and angio invasion, which is not, we will not be able to pick up by FNAC. There is a most important thing. So there's a lot of difficulty in diagnosing or suspect. So most of the time pathologists give report as a thyroid neoplasm. Neoplasm means maybe adenoma, maybe carcinoma. It's very difficult to differentiate. So, but cellular texture, all other things may be able to, but DNA analysis, if you do these cells, may be able to. Otherwise, it is difficult to assess by FNAC because angio invasion and capsular are the 2 important factors which cannot be identified by FNAC. You need a tissue diagnosis, but true cut biopsy is difficult, cannot be done because it's very complicated, it will injure, cause bleeding, may kill the patient. Frozen section biopsy is accepted, but this is not very accurate. It may also give a negative result. So, in such a patient, do a thyroidectomy, send for histology, confirm, on table frozen, on table difficult again frozen section. Then later period, depending on the situation, you may go ahead with the further surgery or go ahead with the radioactive iodine therapy. One lobe, if you remove hemithyroidectomy, if it comes as malignancy, then you have to do a completion thyroidectomy, either within a week of surgery or after 3 weeks, because from 7 days to 3 weeks, there will be a lot of inflammation, edema will be there, difficult to dissect and go ahead to do the completion thyroidectomy. So completion thyroidectomy should be done within a week of initial surgery or of 3 weeks after the initial surgery. Between 7 days to 3 weeks, you should avoid going in and go ahead for the completion thyroidectomy. So non-invasive, blood spread not common. Invasive are the 2 important types which you have to remember. This is naturally more aggressive with the poor outcome, blood spread. Non-invasive, invasive, this is important. Typical feature I already told, capsular invasion and angio invasion. If this is the thyroid malignancy, this is the capsule, it inverts the capsule. If there is a vessels, it inverts the vessel. Capsular invasion and angio invasion, typical feature of FCT, follicular carcinoma of thyroid. Remember that. And treatment, of course, total thyroidectomy, confirmed diagnosis, radioactive iodine 131 therapy, you have to give maintenance dose of L-thyroxine because this is not TSH dependent. TSH will not cause further proliferation of the malignant cells here. Of course, there is a controversy. If it is DTC with the papillary component, you may have to give it. There's a different time. I'm not going to detail that. Follow-up is by radioactive iodine study at regular interval, maybe once a year. Thyroglobulin estimation is a very, very important marker for follow-up actually. So remember, this is a short note thyroglobulin estimation. MCQ they will ask, go through my manual about the value, its significance, where it is secreted. It can assess the thyroglobulin in the lymph node spread also. Lymph node aspirate fluid, if as a thyroglobulin antibody or thyroglobulin as such, it will be a very high. That is a diagnostic. So thyroglobulin estimation is very, in the blood also it is very useful. So blood serum thyroglobulin estimation is very, very relevant in the follow-up period. USG neck, if you need guided aspiration of tissue or node, I already told. Node as well as tissue, you have to do FNAC. TSLH should be more than 30 units prior to radiotherapy or therapy, radiotherapy. Hence, thyroxine should not be given. So after total thyroidectomy, in the DTC patient, never give thyroxine immediately, thinking that thyroxine level has come down. You have to supplement the patient. You have to maintenance dose, supplement maintenance dose. Don't give that because you have to continue and see. Usually it takes 2 to 3 weeks to become TSH more than 30. If TSH level is not more than 30, you may not be able to do either radioactive iodine study or you may not be able to give a radioactive iodine therapy, which is many times needed in the most of our patients because they come with the large size. So do not give thyroxine immediately after growth. It's an important point. You have to wait because you need to do a further treatment, adjuvant therapy, follow-up. You have to do a radioactive study after removing the entire thyroid. So all the things are there. Do not give thyroxine immediately. Later period after study, after first therapy, then you can give. So this is the thyroidectomy. This is the neck dissection done in this patient. See that? So neck dissection you have to do, you have to retain the IAV and so on. Maybe lateral neck dissection or functional neck dissection. Currently it is called as modified neck dissection or selective lateral neck dissection. 2B, 3, 4. These are the things you have to remember. You have to remove. Often bilateral, remember. Often bilateral you have to remember. You have to remove. So remember about FCT, I already told, radio remnant ablation. If there is some tissues retained there, then you have to do a ablation of those things by giving radioiodine therapy. What are the precautions before radioiodine therapy? Already told, dryness of the mouth, isolation, excreta and urine to be isolated. No chemotherapy for FCT. Thyroid TG estimation is very, very important. More than 50 nanograms abnormal. Value is always less than 50 nanograms. Serum thyroglobulin estimation important. Hurthle cell carcinoma with a variant, often as a short note. Viva they will ask, MCQs it will be asked. It is detailedly given current concept about Hurthle carcinoma in my book. Go through that. It does not take up iodine 131. This is the point which is remember often asked MCQ. More aggressive. It is secret thyroglobulin. It's a very important thyroid estimation will poll. It's the most important. 99 the technician Systemabi scan. Systemabi can is very, very useful, often diagnostic. It's again MCQ question. 99 MTC Systemabi scan is very, very useful. This point remember as MCQ question. Why you will ask or theory you have to mention. It is aggressive. Does not take up iodine 131, so that is not useful. That treatment wise also that is not useful in hurthle cell carcinoma, but it's secret thyroglobulin, so diagnosis is easier. Follow-up is important, easier, but this is the diagnostic. This scan, technetium scan is diagnostic in this patient. So that is about hurthle cell carcinoma, often as a short note, Viva, MCQs they will ask. Remember, everything is there in my manual of surgery detail. So this is the newer variety in a newer classification that become very, very become more commonly used and highlighted. That is a poorly differentiated thyroid carcinoma, PDTC. So PCT, papillary carcinoma thyroid, FCT, MCT is medullary carcinoma thyroid, newer one, PDTC, poorly thyroid, an intermediate behavior between the well-defined, that you are already, anaplastic carcinoma. So there is a differentiated thyroid cancer like follicular carcinoma thyroid and anaplastic carcinoma. So in between there is a carcinoma, intermediate behavior, but they are aggressive. That is called as a poorly differentiated thyroid cancer. How to say around 3%, it's very rapidly progressive, causes dyspnea, dysphagia, and encasing the thyroid is very sign positive. Distant threat is common to lungs and bones. So these are the things which are high mitosis necrosis. These are the typical features of this type. Racinoid nuclei, convoluted nuclei, and this is the Turin consensus criteria are used for the diagnosis of this poorly differentiated thyroid cancer. These are the factors. Expression of TG is absent. Thyroglobulin expression is absent in this patient. This is important feature of the PDTC. FNS is very, very useful. Ultrasound neck, CCT, MR, PET-CT are needed in this patient because they are aggressive, may have spread elsewhere in the body. So you have to do imaging and see it is not metastatic, specifically PET-CT. So treatment is total thyroidectomy, MRND, high dose of radiotherapy, external lipical radiotherapy also you have to give. Here targeted therapy is quite useful. Avatinib, sorafenib, that often used for HCC and other malignancies. That is hepatocellular carcinoma. Redifferentiated therapy or different modality. You redifferentiate redifferentiate by different modality. That is a newer concept actually, redifferentiation. So reduce the differentiation and so that make it less aggressive. So there are different methods for that. Prognosis is poor with all these things, with the less than 40% survival. Death is usually 2 mets. Once it is metastatic, naturally in animal you say, outcome is poor, they will die. So this is a very, very quite aggressive, but less aggressive than anaplastic carcinoma. Much more aggressive than the follicular carcinoma thyroid, a in between variant. So important Turin consensus criteria, often asked as a MCQ. It may be eventually asked as a short note in due course of time becomes, it is projected more and more nowadays. An aggressive type between PCT, FCT, between FCT and anaplastic carcinoma. There is a type in between already, is described actually. So differential thyroid cancer, I'm not going to discuss about that. Just highlighting DTC is an entity group put together. Papillary and follicular and arthal cell carcinoma also comes under DTC, but it does not take up iodine 131. So TNM staging you can always read in my book. Newer staging is different 2018. And remember, AGCC staging 8th edition 2018. Now this year 2026, AGCC staging has come as a 9th version. Now they have staging system, they have changed as a version now. Now no more edition is there. So 9th version, number is continued. 9th version, not edition. Now new version has come in 2022 to project official and available. Maybe second half of this year it will be available. So this is change. It is going to change as a 9th version in all AGCC classifications. Will change as a 9th version in the due course of time. So age here is olden days it used to be 45 years. Now it has changed to 55 years. Age factor is more or less than 55 years. Less than 55 years different. More than 55 years. 55. Olden days 45. Now no more 45 years is considered. It's now 55 years. Now again it has become version. Central compartment dissection already told. Completion thyroidectomy already told. Problems with L-thyroxine, subclinical thyrotoxicosis, cardiac osteoporosis. I already discussed that. Thyroxine side effects. Features of thyrotoxicosis natural will be there because high dose, suppressed dose, 0.2 to 0.3 milligram. And osteoporosis, bone pain, osteoporosis. Irregularity, cardiac tachycardia, ectopics common. And how to manage metastatic disease, again different entity. Radioiodine therapy, the main thing. Of course, targeted therapies are available nowadays. Follow up mainly clinical regular interval, thyroglobulin serum estimation. If there is a thyroid level, washout, finish the washout thyroglobulin level, that is from the lymph node washout. Thyroglobulin antibody, that is more sensitive than thyroglobulin. TSH, basic thing, in regular interval, ultrasound neck, follow up from metastatic to PET CT in this patient. So all these things are important during follow up, of course, PET CT and these things, washout thyroglobulin level, only in selected individual. Otherwise, TSH, thyroglobulin level estimation, ultrasound neck, clinical examination. Clinical examination, ultrasound neck, thyroglobulin, TSH, thyroglobulin specific, and thyroglobulin antibody, and thyroglobulin washout from the lymph node or other tissues, and washout estimation, and PET CT. These are the things in selected individual and you suspect you have to do, especially when you think there are spread. So that is about DTC, again common main question asked. Go through that. In my book in detail it is given. I'm just giving the bird's eye view or highlight of what exactly the meaning of the DTC, a common main question, often short note, management asked. So go through my manual of surgery, which is given in detail with the concept. So this is the levels, is that 2A, 2B, 2A, 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 3, 4. This is the central compartment, remember. Central compartment. This is the central compartment up to the innominate vein. So lateral compartment and central compartment, you have to call it. This is for neck dissection, MND or lateral neck dissection, mainly lateral compartment dissection or central compartment dissection. This is the always when positive, whether you do it prophylactic or not is the question. So this is the different malignancies. You can see that is the position of the patient, head end up, Ross position, head end up, neck extended, hands are tugged out. Of course, neck extension is very, very important. Sandbag under the shoulder blade, Cocker's incision, 2 centimeter above the 2 finger width above the suprasternal notch. Go through the skin, platysma, then raise the flap, upper flap up to the thyroid, lower flap up to the sternoclavicular joint. Open the deep fascia midline. Then cut the strap muscles if required, if it is very large, between the two cockers. Then dissect the thyroid. Above, identify superior thyroid artery, superior thyroid vein. Then external glandular nerves, very important to retain the external glandular nerve. Ligate vessel very close to the gland. And ligate the middle thyroid vein, which is single. Often it may be absent first, then superior thyroid pedicle, then inferior thyroid pedicle, away from the gland, but retain the anastomotic branch. Always identify parathyroid, retain it at least one. Always identify recurrent glandular nerve, very close to the Beri's ligament, dissect it and identify it. Very meticulous dissection. You can use monitors to identify the recurrent laryngeal nerve, and also Paris ligament to as a marker. And both sides you should retain. Parathyroid, at least one parathyroid should be retained, and remove the gland. Absolute emotions is important. Place the drain and close the wound. That is how exactly you do the what is called as a total thyroidectomy. Two structures are important: parathyroid, recurrent laryngeal nerve. Parathyroid, recurrent laryngeal nerve. This is the staging system. I'm not going to detail it. Read my book. And anaplastic carcinoma is undifferentiated, most aggressive, lifespan is short, swelling, fixity, Berry's sign is positive, stridor rate already discussed. Always it is stage 4. In that you can classify A, B, C. There is no stage 1, 2, 3 for anaplastic. Once you say anaplastic, always 4. Surgery in 4A, external radiotherapy, adriamycin. Here adriamycin is useful, remember, drug. All other thyroid say no chemotherapy, but here, of course, targeted therapy can give. Some they need tracheostomy sometimes, worst prognosis, anaplastic carcinoma. So there is a poorly defined thyroid cancer between the FCT and anaplastic, and it has got a worst prognosis, remember. So it's the important thing. Papillary carcinoma thyroid long-standing can turn into this one. Very, very aggressive, remember, difficult to treat. So medullary carcinoma thyroid, 5% derived from parafollicular cells, C cells, type sorodic, MCT, and familial amyloid stroma. That is important. Familial nature is most important thing. Calcium specific tumor marker, I already told MCQ question. These things are FNAC shows amyloid stroma, diagnostic. And syndromes often is MN2 syndrome. No role of radioiodine therapy, radiotherapy, because it's not related to the per se thyroid gland or thyroid function. Familial heredity is very common. Nodular, often neck nodes, can spread to the lymph node, can put the blood also. See, these are the harm features are important. Diarrhea, hypertension, pheochromocytoma may be there, association like a part of the MEN syndrome. Evaluate for pheochromocytoma by other markers, noradrenaline and other things. VMA, all those things. Screening all members with the calcitonin level. Calcitonin is the most important thing. Remember, it's often a short note. MCT is a short note. So prophylactic thyroidectomy we have to do in these patients. So read my book, it is given in detail, but this basic thing, this chart, this slide will give to remember amyloid stroma, calcitonin, family member, lymph node dissection, surgery is the main treatment, no radioiodine therapy, and screening the family member. All these points are important when you think of medullary carcinoma thyroid. It's a 5% common arising from the parafollicular C cells of the thyroid as such. So I'm not going to detail it. It's secret. All these things, pheochromocytoma common, CT neck, abdomen have to do. This is the one which is useful to detect NCT, 111 indium total thyroidectomy, the lymph node dissection, central node dissection also you have to do. External beam radiotherapy, not radioiodine therapy, remember. Maybe these are useful. Maintenance dose of thyroxine is important. Prophylactic thyroidectomy when there is high serum calcium in family members. Screen all family members for calcitonin level. That's a very important marker in MCT, remember. This is the total thyroidectomy patient with the lymph node dissection for thyroid carcinoma, probably FCT. And last at the end, I will remember how is Emil Theodor Kocher, very fond of this person from the Switzerland, Bern. 100 years back, he got 2011 or 11, he got Nobel Prize for his extensive work on thyroid surgery. You know that Kocher's vein, Kocherization, Kocher's instrument, Kocher's incision, Kocher's mobilization, Kocher's method of shoulder joint reduction, and so many Kochers are there. Kocher's instrument is there. So did extensive work on surgical aspect and specifically related to the thyroid surgery. Surgery which we are doing is still conceptualized 100 years back by this man, and still worth to be remembered always, ever and ever. He got the first surgeon to get Nobel Prize, Emil Theodor Kocher. And Alexis Carrel, the next one, Christian Bernard, who did a heart transplantation, was the next surgeon who got the Nobel Prize. The first surgeon to get Nobel Prize, Emil Theodor Kocher. Kocher may be short note, why were they will ask. It's interesting to know the history to an extent, especially people like Emil Theodor Kocher, remember, because they did a great job to the surgical system as such. So remember history of present, I'm not going to detail it. It is there in my live session. We can go through that. I'm just putting the slide out, examine a patient, swelling, pain, history, what are the things. Just remember this slide, family history important, general eye signs are important. All these eye signs are important. I'm not to go into detail it. And again, inspection, what to do. Movement of the deglutition is the most important. Pizzol's method, WHO grading, Kryle's method, Cocker's test, Pemberton sign, trail sign for trachea, lower margin is most important. Leahy's method again. Pulsatility, thrill, plane of the swelling is important. Where you contact the neck like this or like this. So tendocardiomostoid muscle should be contracted. Cardiac pulsation, superficial temporal artery, all these things. Thrill in the upper pole, breathe on the upper pole, not lower pole. Because superficial thyroid, superior thyroid artery enters the gland superficially, superior thyroid artery. So all these things are important when you examine a patient. This is the other thing, oral cavity, scalp. For second is percussion, whether retrosternal extension is there or not. Axial door, low occultation, upper pole, is the cervical nodes important. Without that, your exam incomplete. Abdomen, skull, respiratory system, carotid. And for toxic thyroid, ankle jerk, skull, spine, all these things are the important examination. This is exactly you give the diagnosis, carcinothyroid, solitary nodule, which site, euthyroid, with the nodes or with the nodes, with the lymph node or with the node if it is malignancy. And how we will manage? Evaluation, quadruple assessment, clinical, sonological, FNAC, biochemical, triple assessment in the breast carcinoma, breast swelling, breast lump, thyroid swelling, quadruple assessment, clinical, sonological, FNAC, biochemical, T3, T4, TSH. And treatment, I already told malignancy, how to do so. You can read my book, manual, surgery, everything is given in detail. So, solving with the deglutition, berry segment, lower border, butterfly shaped, Kryle's method, plane of the swelling, contact tendocardiomostoid muscle. See that? This is how exactly we'll examine the patient. Kryle's method, trachea palpation, trail sign, toxic thyroid, examine the both shin actually for the pre-tibial mixed edema, which is a misnomer seen in the toxic thyroid, and Leachy's method of examination. This is Nafziger's sign, this is Mobius sign, this is Van Graaf's sign, this is Joffrey's sign. All there are so many 20 signs, but remember these signs enough. Nafziger's, Van Graaf's, Mobius, Joffrey's sign. And this is the different thyroid nodules, toxic thyroid, colloid goiter, male thyroid, remember, high risk actually, and malignant thyroid, ectopic thyroid here again, malignant thyroid. This is also malignant thyroid, advanced anaplastic carcinoma. So remember all these things in the important thyroid. These are the things which you have to remember always. Kryle's grading, retention for thyroid steel, paradox, lateral aberrant thyroid is a misnomer. It's a lymph node in a papillary carcinothyroid. There is no lateral aberrant thyroid. It's a misnomer. Often asked, it's MCQ question. Different threads, eye sign, Berry's ligament, Berry's sign. Lingual thyroid, pre-tibial mixed edema is a misnomer. It's not mixed edema. It's not hypothyroid. It's hyperthyroid. In that primary toxic or Graves' disease, specifically in the Graves' disease, exophthalmos, causes of goiter, classification goiter, important. You have to remember. So remember this thought. All these things you have to remember. Very relevant when you examine or delay patient with the thyroid swelling, in general, in specific thyroid malignancy. So students, please subscribe my YouTube channel and share with your friends and colleagues. And already around 500 video lectures, live sessions are going on. Join live session and you will understand how they present different cases of hernia, varicose vein, vascular disease, breast lump, swellings, everything is discussed there. So the students are presenting, different faculties are discussing, and so that how you present in the exam, how you learn these things will be. They brief, my lecture will be there, how to examine a patient. So go through that. There are MCQs, almost regular intervals, a lot of operative procedures are there. Different discussions are there. Lot of videos are there. Please go through the surgery, go through it and learn surgery easily, comfortably, in a better way. And always have my manual of surgery with the current edition, with the MCQ book. Lot of things are there, footnotes are there, detailed discussion about different diseases, different chapters. Everything is covered as far as CBSE syllabus is considered. And treatment strategy, investigation, lot of diagrams, photos, lectures, investigations, illustrations are there. Please go through that and learn surgery in a better way. Of course, my clinical methods in surgery, current edition gives a proper examination method with the video of examination of all procedures. You go through my clinical methods, I go through my manual of surgery, and go through my website, YouTube channel, so you can learn surgery completely, properly, to face your practical exam and theory, Viva, NEET, like entrance exams also. That is more than sufficient. Please again request subscribe my YouTube channel, SRB Surgical Insight, which is free and it is very, very useful to learn. And of course, I always have my manual of surgery and clinical method to learn surgery in a different way, proper way, perfect way. So students, I hope you have understood this topic very well. Thank you so much.